Our first speaker has run workshops for us before, comes from UMass at Amherst, is Hari Balasubramanian, a colleague of Jenna Markworth's, and is really going to talk to us about workflow, and quantifying workload, rather, in primary care challenges and directions. So Hari, if you'd be so kind.
Yes, so it's been a great conference to be at to get the feedback of clinicians. And as John mentioned, I organized a workshop last year, and I got, I had maybe 20 clinicians in the audience. It was great to hear their thoughts on the kind of work I was doing. I wanted to speak today about sort of the kinds of questions I work on have to do with capacity imbalances for physicians and care teams, and that's what I mean by workload in general. And for the for the last 10 years, so it's interesting. I actually started working in primary care in 2007 when I was at Mayo Clinic. I spent 2 years at the Mayo Clinic, and I was using some of these industrial engineering methods to improve primary care delivery. And so it's about 10 years now. And at that time, I did not regard it as, I thought of primary care delivery as a problem similar to, let's say, elective surgery scheduling and some of the other issues of patient flow that I was dealing with. But as I got to learn more and more about primary care, I realized that it is, I started to like it a lot more because it doesn't look at the person or a particular visit only. It actually puts things in context, right? So primary care is about holistic care, a comprehensive approach. It's not just about a particular visit or a particular event. It's about understanding where the patient is positioned in this sort of network of things that are going on in their life as well as in the health system. And so I started to appreciate that a lot more. And if you really think about what a systems engineer does, they don't you think about all the aspects and angles of a system. You don't necessarily say, I'm going to fix this one piece. And often that one piece, if you may fix that, and you may find that that's a very myopic approach, and that causes problems downstream. In a hospital setting, for example, you may get the best elective surgery schedule only to find that the inpatient units downstream are having issues because of that schedule. Or you may fix the emergency room, you may have problems downstream. So as systems engineers or industrial engineers, we're designed to think broadly about all aspects of a system. And so that ties in very well with the primary care approach also, which tries to look at the person as a whole, not just one disease. Where you're not dealing just with diseases, but diseases operating in a particular person. So this started to grow in me. This idea of what primary care is started to grow in me. But the problems I was dealing with for a long period were not capturing this element as much. You might say that I was working on, let's say, appointment scheduling of a particular morning session of a primary care office. A scheduling problem, which patient, how to double book, what's the impact of no-shows, what's the face time with provider, how do you schedule patients in a particular session, right? And so you schedule that session, and that's it. There's no memory of what happens to the patient afterward. There's no memory of what the provider does afterward, and so on. So it's a very, what you might call a very limited type of scheduling problem. Very important still, because primary care offices, wherever I've been, have a fair degree of uncertainty and randomness, and the problems remain challenging. But I worked on all these problems and realized that they were not quite dealing with maybe the full sense of the patient perspective. Let's say panel size is one of the problems that industrial engineers always address in the primary care setting. Panel size is how many patients a primary care physician cares for in the long run. Essentially, we dealt with it as a supply and demand imbalance problem. If you have a certain number of patients, that generates a certain number of visits. You have a certain amount of time that is left that you have to see these patients, and the interaction of these two causes some delays in care, right? But you still don't see. You see it just as there's some sort of demand, some sort of supply, but you don't get the holistic view of each individual in the panel. And so while I was working on all these things, these still remained problems. I realized that maybe I needed to fundamentally reconfigure. I'm still interested in the same questions, but I needed to reconfigure my methods to be more in tune with how primary care physicians think about the problem. And so that's what this talk I will try to emphasize on, and is how does workload come into play, given that we don't just think of it as an isolated afternoon session or a morning session that we're trying to schedule, but we try to bring in the perspective of the provider and the patient together in a single longitudinal framework evolving in time. And that's kind of the main idea, and try to get to the same questions I spoke about, panel size, workload, once within this framework, within the context of this framework. And one of the things I really wanted to bring in was not just that a person has an office visit and then the model has no memory of what happens to the patient afterwards, or what perspective the patient is coming from, but somehow hold the patient perspective in the model itself in some manner, in whatever manner possible. So that's going to be the outline of my talk, and this is the framework that I will present today. And the examples I will use individual patient examples. One is from a New England Journal of Medicine article from 2014. I will use some data I've been looking at in the Medical Expenditure Panel Survey, which is run by AHRQ, one of the sponsors of this conference, at least in the past, this year too. And then another problem about a multidisciplinary care team, workload of a multidisciplinary care team that I've been working with in Camden, New Jersey. So those are some of the ways or examples which will kind of around which the whole discussion will pivot. So if this still sounds abstract, I thought I'd generate a figure, a little animated figure that will try to describe what I'm trying to achieve in this sort of framework in which I capture both the provider and the patient together in a longitudinal approach. And so let's take a simple example. There's a 33-minute office visit that a particular patient 1, let's say, it would be better to have a name because you always want to individualize things a lot more. But let's say it's patient 1 with the PCP has at a certain moment in time has a office visit. Let's say it lasts 30 minutes, 35 minutes. You could also be more precise. So that's one office visit, but that office visit happens at a certain moment in time, and so the provider has a certain timeline. Provider and the care team, let's say, has a certain timeline. The patient also has a certain timeline, and let's say this timeline is not hours, but it's days or weeks. And so before that visit, a series of things or events could have happened to the patient in the health system. Maybe the patient met a specialist, maybe there was a hospitalization and a discharge, maybe there were changes in medication, especially if the patient has multiple chronic conditions. You would see in today's way in which healthcare is delivered, usually there's a lot of different tests, medication changes, specialist visits, all kinds of things happening that the patient is experiencing over time. And some of these are, the PCP becomes aware of them through other means, but these are not things that happen within the PCP's office practice. They may be happening elsewhere in the health system. So the patient comes to this visit with a certain history of encounters. And ideally, we'd also like to know the things, as I said, primary care tends to be very holistic. We'd also like to know not just these clinical events that the patient is coming with, but also any other job or family events or social characteristics that have some relevance to the patient's timeline, so that you can more and more capture what the patient is experiencing in time. So when that office visit happens, there's a history that's involved. And those series of events the patient is experiencing, I use different shapes here. Again, maybe the triangle could be a specialist visit, a cardiology visit. The square could be a neurology visit. A hospitalization might be that red cross there, and a discharge after that. So there's what I've noticed is that these timelines get extremely complicated for patients. What also seems to happen is that there's a lot of what you call information flows that are going on between the PCP's office, the PCP's care team, and the patient, which are not really direct face-to-face visits. They might be inbox notifications, changes in medication. They might be emails that the patient initiates through the portal. They might be emails that the physician initiates. So I've left them as dotted lines, and they tend to be much more intense than this. But it could be something the specialist wanted to know from the PCP about this patient. It could be something the PCP wanted to know about the patient, or the patient's family member calls. So there's a lot of these interactions going on in time, which are less easy to capture. They are there in the EMR somewhere. They're less easy to capture, however, but they do form a part of the provider's, what you might call the work burden or workload. So you've got now the patient experiencing a series of things that sort of creates this projection onto the provider's timeline of things that the provider needs to take care of, or at least information that gets passed on that is somehow relevant about that patient when we come to that office visit. And so after that office visit, in the next series, you could again have, as things progress in time, you could once more have a whole series of interactions, information flows between anything that is relevant for the patient, between the patient and the provider and the provider's care team, and then a future sequence of events unfolds in the patient's timeline. So here we have, this is what I mean by jointly evolving longitudinal trajectories. One is the PCP's trajectory, which kind of takes on which takes on the work of a particular patient in time, and the other one is the patient's timeline, which experiences a sequence of events in time. And so usually, if this could be like a period of days or weeks or however you want to think about it. In this period or a time period, it's not the only patient the provider is dealing with. You've got, patient one had that sequence of events. Patient two might be a new patient who's visiting for the very first time, hasn't had any health events so far. That might be a 45-minute visit with the provider. It might be, this is a new patient, so therefore it was a long visit. And then you've got right after patient one, the provider will be seeing another patient, patient three, and that might be a 20-minute visit. And each of these patients also has their own interactions going on with their provider, information flows that are going on between relevant to each patient and their provider. And so what we have is essentially, I've just given an example of 3 patients. But imagine usually a panel consists of hundreds of patients, right? And let's say this is a month or a week, so it's not just 3, but you could stretch it out to many more timelines like this that project their work onto the provider's calendar. In the meanwhile, the patients are also evolving. Patients' events or sequences of events are also evolving in time. So what we see here is that the patient's timeline, the workload is dynamically changing. It is the aggregate of all the demands that are projected by information flows related to each patient in the panel. And so it's kind of the sum of all that is what you might call the workload of the provider. And so what you're seeing these days is, of course, I made these dotted lines as the conceptualization, but time studies and other methods are showing increasingly that the time spent in office visits, the ratio of the time spent in office visits to that spent processing information flows, coordinating care, going through all these notifications that physicians receive in their inboxes. These dotted lines are becoming increasingly dominant as our health system becomes more and more fragmented, highly specialized, and so on. So this is what I was referring to, and there's a way to reconstruct these joint patient and provider histories through digital traces in the electronic medical record. Not everything will be available, but I think it can be made more and more precise and granular as much as a provider would like. Often it's difficult to get all the pieces of information, but I think some of these longitudinal histories can be constructed with the data we have. So I want to make it a little more concrete. So that was just an abstract example. But here's an example of this is from the New England Journal of Medicine. This is a 70-year-old man, Mr. K. Mr. K's physician was Matthew Press, who was an internist at Mass General Hospital. This 70-year-old man had no major medical events up to a certain point. except for the usual routine visit. But a CT scan on one particular test showed a CT scan of the abdomen, and the patient was having some fever and some flank pain. A CT scan of the abdomen showed a kidney stone and a 5-centimeter growth in the liver, which then had to be checked with an MRI, which there was a suspected carcinoma there. And so that led to a whole sequence of encounters, an escalating series of encounters for that patient in the other parts of the health system. And while so there, this is the I apologize, this the colors aren't showing very well. But you can see here there was phone calls. That's the blue one there. There's emails. There's procedures, and there's office visits. And you can see there were over an 80-day period, 12 clinicians were involved in the care of the patient. And this was not based on the electronic record. This was something Matthew Press, the internist, actually kept track of all these things by hand, and tried to sort of create a timeline over 80 days, exactly like the one I described on the previous slide. Over an 80-day period, 12 clinicians were involved in the care of the patient. The patient's primary care physician communicated with other clinicians 40 times, 32 emails and 8 phone calls. So this is those dotted lines I was referring to in the previous slide. And with the patient or patient's wife 12 times. The patient's perspective is that they underwent 5 procedures and 11 office visits, none of them with the PCP, in fact. But the PCP is communicating constantly with this whole satellite of providers. And so from day 0, when this escalation of events began to day 80, the physician kept track and created this graph, and there's actually an animation of this also that we can take a look at if we have time at the end. So it starts empty and starts filling up and gets very, very complicated. It was day 32 when a lot of these events happen. And so you can see how complex care can get. And there was not even an office visit with the primary care physician in this time period. Now, this physician said that they had only, maybe they were on the side of retirement, and so they had only 90 patients to deal with. So you can imagine that this was one escalation in a certain time period. But if you have a panel of 1,000 instead of 90, then you can imagine all those patients projecting their own demands and needs. And this physician said this wasn't simply a matter of costs or anything. It was actually a safety issue. Labs had to be properly checked. A lot of the work had to be done on weekends because some labs were closed on the weekend, so the physician had to call to make sure that the lab was scheduled for the patient over the weekend. And so, so there was a lot of these things. But now, if you have many patients, you start to see, how sort of the calendar starts to fill up in time. Yeah, it would have been really nice to have those colors, but Yeah, so I think broadly, if you want to deconstruct the workload of a provider, we can think of it in terms of office visits where there's time spent with the patient. Actually, there's some information. There's a time study by Christine Sinsky tomorrow based on an analyst paper, which suggests that even during the office visit, there's actually not enough face time. The EHR still intrudes. But let's say that you've got office visits, and then you've got this burden created by information flows and coordination needs, which is a little more unstructured and harder to quantify. It's almost as if this effort is sort of on the mind as a cognitive load on the provider, that this thing has to be done, these things have to be taken care of, and there's only maybe a certain number of things you can imagine taking care of in a certain time period. If the information overload is too much, so that burden, so obviously there's going to be some inefficiencies or concerns if the provider is not able to keep up with this information. So in queuing theory, we have a very basic result. It's a purely mathematical result. It says that you have a certain amount of time, which is your capacity, and you have a certain demands on that time, which is sort of demands the time that the patient needs from you, and that demand is uncertain because you don't know how many visits they'll need, how much coordination they will need. But we know that, for example, when the average demand generated by your panel gets closer and closer to the time you have, then your ability to provide access, which is this queue length here, or waiting times or queue length, starts to really just take off. And it's not a linear thing. It looks good until that average. This is what you call utilization, or you might say the proportion of time you're busy, this ratio here. But as this ratio, if your average demand is equal to the average capacity, you are certain to have massive delays in your system. There's going to be, you're going to find it very challenging to provide timely care. And so the mathematics says that, okay, well, around 85% to 90% is when the system really starts to take off and become very, very challenging from a viewpoint of your ability to provide timely access. So this is just based on a derivation. This is a mathematical derivation. You can calculate this. And what I'm thinking is that so when it comes to just time, when you're thinking of office visits, certainly that applies. But when it comes to the burden created by all these information flows, certainly there's information has become a lot easier to send around. But it also means that it resides in many places. You have to sort of put some effort to bring it all together and make meaning to it. And so information gets sent easily. It's instant. It's all electrons in the end. So it's near light speeds that information gets transmitted. And so you see information flows are very easy, but I don't think our brains have kept up pace with how much time it takes to process that information. And usually the information is very high dimensional. Lab tests, certain other characteristics, and you can keep adding the columns for just one patient. And it gets very complex to process mentally. And so while the sending of information has become very easy, the processing of it and making meaning of it still takes a lot of time. And so I'm going to hypothesize here that curve, which looks like that, this is a hypothesis, this is not a mathematical result. I'm hypothesizing that actually that curve actually starts to bend much more quickly in the very information-rich world that we actually are in, is that even at a lower average demand to capacity, just because there's so much going on and so many inbox notifications, there's so much to keep track of, is I wonder if that curve is actually, it's supposed to make things easier, and obviously the IT revolution has made things a lot easier, but I wonder if it actually bends the curve a lot earlier than it normally would. So I apologize, this table is also a little busy, but I will come to it. So we've been looking at, so obviously the case we saw over the escalation of the patient's events over an 80-day time period. We saw a lot of events happen. But that's not true for all patients, right? So if you have a panel of 2,000 patients, and so we sampled a nationally representative panel of 2,000 patients from the Medical Expenditure Panel Survey. We constructed their longitudinal histories for a full year. Every day, what events happened to them. And so essentially you can say on June 31st, your panel had these series of events. So we constructed their longitudinal histories. These were patients over 18. They responded yes to having a usual source of care or a primary care provider. And we used 2,000 because that's usually, in the literature, you find 2,000 as a normal size for a primary care physician's panel. It's not true because there's no one size fits all. But let's say that we start with that. So 2,000 patients who are nationally representative, let's say they all live in the same town that represents the American demographic, and they are attached to the same physician. So these 2,000 patients all say yes to having a PCP. We have their whole history for 1 year. And so if we analyze their patterns, we do see that a third of the panel does not request any visits at all. So these are PCP visits. How many PCP visits those 2,000 patients had in a year? And so there were 687 patients who had no visits at all. 442 patients who had exactly 1 visit. 271 patients who had 2 visits, and so on. You had 15 patients who had 20 plus visits in a year. And if you plot that in a curve, you see a curve that looks as if it was generated mathematically, but it's not. It's actually a histogram, which I just presented with a smooth curve. You see that a small number of patients have a large number of visits, and that's your primary sort of, you see this pattern not just in this, but any data set in healthcare data set, just as costs are concentrated in a small amount of people, in the same way, by definition, because of costs are because of utilization, so utilization is also concentrated in a small number of people in your panel. Now, this other thing here is how many unique specialists did that panel of 2000 see in a year, unique specialists other than the PCP. So there were 883 panel members who did not see any other specialists other than the PCP. We had 318 who saw one other specialist other than the PCP. We had 213 who saw two unique specialists, so these are two different specialties. And so we start to see again the same trend there, is that a large number of people have no need for specialists, just a few specialists, but you had one person who was seeing 11 different specialists in a year, right? And so if you think about the graphs I've showed so far about the evolving longitudinal histories, what's good about this is that a lot of those histories are likely to be empty, nothing happening. But then for those few patients, you're having a lot of coordination workload because they're seeing a lot of different providers. You could also match how many saw 18 visits and saw 5 specialists and had a certain number of ED and inpatient events. Because we have this longitudinal information, we can answer that question for a specific patient, for a group of patients. We can also get the aggregate performance of the panel. So for example, this panel generated about 4,800 annual visits in that year, this panel of 2000. So if you're working for 50 weeks and if you see about 100 patients each week, if you're working for 50 weeks of the year, then you have a capacity roughly of 5,000 patients. And so this is about 4,800 visits. But again, the ratio then would be 94%. It's too close to the capacity. And so you'll have wait times just for the visits or delays or overtime or whatever for visits. But that's not even counting how much time you might have to spend to coordinate the care, because patients are now seeing all these other specialists, which generates all this information workload burden. So the point of this was that you could get to the individual, what happened to the individual, the full trajectory of the individual, but you could use that because the provider's workload is the aggregate sum of those individual patient summaries. I'm going to shift gears a little bit. We're going to talk about a different kind of problem, and I think it's interesting for a variety of reasons. The context here is we'll use the same exact methods of longitudinal histories and workload, but in a totally different context. And this context is based on a care team, a multidisciplinary care team in Camden, New Jersey. And I've been working with this group for the last 2 years, and we've been analyzing some of their care team workload data. And so this example is, so this care coordination idea, intensive care coordination, was started by Jeffrey Brenner, who was a family physician. He then realized that that he needed to start this type of care coordination model involving nurses, social workers, health coaches, and community health workers to help a small group of patients who were incurring a large number of expenditures or healthcare costs, who had both clinical and social problems that were intertwined. And so he decided to start a care model, which is called the Camden it's called CCHP, the Camden Care Coalition model, which involves this multidisciplinary care team to help patients get back up and reduce some of this unnecessary utilization due to ED visits and inpatient stays that are prevalent in the 1% of the top percentile of patients. So this is an example of such a patient. His name is Miguel. The driving diagnoses are hepatitis, congestive heart failure, and hypertension are the diagnosis this particular person had. You have also a very, very high number of issues in the social realm. The patient is unemployed, does not have an income, there was no insurance. This is back in 2012 or 2013. The patient also was homeless, there was no housing, there was also active drug use that this patient was experiencing. Before the care team enrolled the patient, in the 9 months prior to enrolling the patient into this care coordination program, the patient had 3 ED visits, 7 inpatient stays. The total bills were $112,000 in that 9-month period. When the care team started working with the patient, there were a number of goals to get the patient insured with Medicaid. Somehow address this issue of drug use, behavioral health, and these were the goals that the patient wanted to address the clinical issues, get onto some kind of behavioral health program, have a stable living situation, have a stable housing situation also. Stay connected to family. So these were some patient goals. And so right after enrollment, a whole series of encounters began where the care team started helping this patient achieve all these things, right? And so what this care team is unique for is that they have a lot of encounters, home visits, accompanying the patient to the PCP or the specialist, buying the necessary equipment, making the calls to the insurance to make sure that the patient now has Medicaid insurance. And so for everything they do, they actually track down how much time they spend. Every encounter, they actually list, maybe they spent an hour on this particular home visit, an hour and a half on a second home visit. If they're doing a phone call on behalf of the patient, that might just be 3 minutes. And so for this particular patient, every encounter and every care team member is recording their sort of workload, you could say, or how much time they spent with this patient. And so that leads us to the longitudinal history here. So again, once we have a timeline that goes from 9/2012 to 3/2014. So that's a long time frame. This is when the enrollment happened, right here. And you can see the ED visits and inpatient stays that caused a lot of costs right up to that. There was a first engagement attempt which was not successful. What the care team does is they get feeds from Camden's area hospital. So Camden, New Jersey is a town that's struggling a lot economically, but they do have hospitals that send their feeds to this care coordination team. Using those feeds, the care team then decides, should we show up at the bedside of the patient to ask if they would benefit from this care management program. So they show up at the bedside, and that's when the enrollment happened right there when the patient was in an inpatient bed. And so the post-enrollment timeline, I have highlighted the major events. Actually, if you listed all the events that are happening, it would be lots of dots. A lot of things have to be done. But the major highlights are, for example, that the patient was now enrolled into a drug rehab program right after the enrollment. They took care of some transitional housing. Rutgers behavioral health program enrollment was also carried out. There was a cardiology visit. And usually the goal is to connect the patient back to their primary care physician within 7 to 14 days. In this case, it happened after 2 months, so there was a delay. But that's an important milestone for the care team, is to get the patient connected back to a PCP. And then there was some sort of living recovery center event. There was an inpatient stay towards February 2014. And finally, we also know now that the Medicaid was approved. Social Security income was also approved for this particular person. So the person did not have an income before, did not have insurance before, but now some of those things have been addressed. This patient was, you could say, very happy with the entire process, has been drug-free since 2013, so right after enrollment. Also volunteers now to help other patients do these things. So it was what you might call, in this particular case, a success. They were able to track the decrease in costs. So you had 3 ED stays, 7 inpatient visits, 61 days in the hospital went down to 0 ED visits, 1 inpatient stay, and 3 days in the hospital post 9 months. And the bill was about $4,000 compared to $112,000. Of course, this could just be pure chance. That's one of the difficulties in measuring some of these things, is that this could just be regression to the mean. And so there's always caution to be used in interpreting this as a success. But the point is that these outcomes are being measured. The other outcome, which is the workload part, to achieve that outcome, to make sure that the patient was a success, the care team had to spend, for this patient alone, the social worker had to spend 139 hours of their time in the post-enrollment phase. And if I plotted that, the social worker's encounters would show up on that timeline. 58 hours of the LPN's time. I apologize, I did not anticipate the colors to be not so, it's supposed to be one of the things that works well and sort of has, at least the audience may like it. But anyway, so you have 58 hours of the LPN's time on this particular patient. We also have community health workers time 15 hours, and then this is the health coach's 24 hours. Some of these are joint because you do home visits together. So an LPN and social worker might go out to the patient's home and spend an hour and a half. And so these are not independent of each other. There's some that are done as a team. This is interesting to me in several things because a lot of things are being measured. The workload, the cost outcomes, the impact on the patient are all being measured. And at least, this is also interesting because the primary care teams might not be so intensive in their coordination, but you could approach the same idea there too, where you're maybe working with a subpanel of complex patients, and then you could similarly measure workload and outcomes without any expectation that things are going to work out perfectly. But at least you could measure both the workload and the outcomes in a similar fashion. In the literature, at least, I do not see this level of granularity and detail of workload measurement for care teams. I do not see it so much for physicians, but at least there's a bit more structure to the physician's time is measured much better. But there are many practices around the country that have initiated similar efforts. The question is, what's the effort of the care team? What's the cost outcomes? What's the impact on the patient? All of those things still need to be evaluated. And this program was good because I felt that you could at least quantify this in some way. So going back, once again, we have the longitudinal history. Once again, we have the workload measurements at the individual level. If you had a lot of these patients, then you could get the overall workload of the care team across a panel of patients. Miguel was a success. This patient was a success. This patient graduated from the program, but a lot of patients are incomplete. They are not successes. And in fact, that's what I'll show you. This is one person's story, but if I looked at 491 individuals who went through this care team, this is a two-dimensional grid. The yellows are not showing well, but I'll try to explain it. The yellows are the oranges. So this is how many weeks they spent in the intervention program, the care team's intervention program. They're supposed to graduate after some point once they're connected to their PCP and their specialists. This is weeks since assignment. So week 0 is when they started their enrollment. The y-axis is how many cumulative care team hours, how many hours did the care team spend with that patient cumulatively in time, right? Now I've divided that into this rectangular grid, which essentially says these are mutually exclusive subsets. It says that there were 127 patients who had their intervention length was between 13 and 143 weeks. And they took more than 63 hours of the care team's time. Of those 127 patients, 107 graduated, like Miguel. 5 of them were either deceased or moved out of the city. And there were 15 of them who were lost to follow-up, repeated failed attempts to engage, no longer interested in services. Right? And so 192 of them spent required between 21 and 63 hours of the care team's time. Also had required more than 13 weeks. So 13 weeks is roughly 3 months. And that's what they expected their intervention duration to be. But it was obviously, most patients were taking much longer. You also had, most of the incompletes seem to happen in the early phase where the patient initially says yes, but within the first 13 weeks, you're unable to reach the patient. And you see a high rate of incompletes in the early part of the intervention. This here is based on where, this data is based on 491 individuals. And so the way it works is that you can actually chart one person's movement in this grid. So this yellow line that's going up, somebody who finally ended up there would be an incomplete patient who ended up in that part of the grid. If there's, I hope this shows up better. Yes, there's a blue line which starts at 0 somewhere here and then moves through this grid and finally ends up in a certain part of the grid. And so we took this data for 491 individuals like Miguel, and we were able to figure out how much time the care team, retrospectively, how much time the care team is able to spends with each person. So again, the individual thing was captured as well as the overall aggregate workload of the care team was captured. So anyway, so those were two examples, one in the primary care setting, one in the care team setting, where I thought there's a way of capturing these longitudinal histories and trying to infer some of the workload patterns for a care team. One thing that I also wanted to touch on, I have, I think, 5 more minutes at least, so I will mention it briefly, is that once we capture the patient's experience, that's one of the things we're saying, that we want to capture the patient's experience. We can objectively capture what events happened to them. We can objectively capture what clinical tests they had. But there's a lot of other factors that are going on in the patient's life, which we would like to capture, but is quite challenging. And I think there's a new framework out there, which is proposed by Victor Montori's group at Mayo Clinic, which actually tries to think about what we call minimally disruptive medicine. But its basic core is that just like we think of the provider having some capacity, we should also think about the patient having some capacity, and that capacity is consumed by the workload. The workload is just life's demands, job, being maybe family, kids, all those life's demands, and the things maybe you would like to do, right? Nobody wants to be a patient, and so you've got life's demands impinging on your capacity. Your capacity could be, it's very qualitative and difficult to pin down, but you might say emotional, physical, social, financial capacity. This capacity refers to all of those. And if you have the demands of life, and then you have the demands of treatment. So for example, if you're one diabetes patient that I looked at had 79 visits in 2 years across 13 specialists. Imagine just the burden of coordinating transportation, calling, conversations, paperwork that adds up across a period of time. So that's what we mean by the burden of treatment. And then, of course, you've got, when the capacity that the patient has is not in balance with the workload of the patient, the workload includes the healthcare workload that the patient has to go through, then the patient starts to prioritize. Just like any provider would prioritize activities, the patient starts to prioritize, and maybe there's not so much adherence that as you would likely to see, and that affects your outcomes. And then maybe there's a kind of a feedback loop there in which the health outcomes get worse, which then of course affects the capacity of the patient, increases the workload on the top side. And so this is almost like it spirals in a certain way, especially for patients with multiple chronic conditions or patients who have complex social needs in addition to clinical needs. And so the idea behind this is that measuring this is very, very challenging. But what I was thinking is that if we have a longitudinal framework for the patient, if we are somehow able to capture something of the capacity of the patient, the resilience of the patient, the emotional needs of the patient, or the social needs of the patient, could we then put that onto the timeline also? Currently, our timelines consisted primarily of events which, as such, don't have any meaning. It's really how the patient perceives those events that really has meaning. So if we can do a more mixed methods study, which involves both the sort of the objective longitudinal histories and also the subjective histories that the patients bring to them, then maybe we have an even more comprehensive framework in which you can evaluate workload and patients' perception of it simultaneously together over time. And that's really what I was trying to get to. And in some cases like AHRQ, this was a patient with diabetes patient with other chronic conditions. From the data set, they do collect things like what the patient perceives their physical health status and mental health status, how they feel about what the PCP did in a 2-year period. These are some survey questions about the PCP. And so you could start plotting these two on the timeline. So these are 5 rounds, so that's actually month 1, month 6, month 12, month 18, month 24. So this MAPS collects data for a 24-month period. And so you could start to see how patients assess their physical health, how they assess their mental health, how they feel about how their doctors are coordinating their care, whether they're showing respect or not, whether they're explaining all the options, and so on. So that's something would make this framework even more robust. I'm not expecting any clean results in this framework. I think it's going to be confounded by all kinds of factors, but I still think it's a bit more robust than just saying that the workload is something and there's a certain number of demand. Without the context of that demand, without the context of the patient, you might not be able to deliver, design your workload so that in an effective way. So just I had a few things to wrap up. I just said that you could use digital traces to create these longitudinal histories. I think we have some availability, at least on this front. The limitations are the data reveals what happened, not what should have happened. And so there's always a bias in the data set as a result, because it's essentially, it's not maybe the ideal thing was the visit should have been scheduled in a month. It ends up getting scheduled in 2 months. So the data is going to show 2 months, but the data set is fundamentally high dimensional. So this is where machine learning and probabilistic algorithms will come into play to find broader patterns. And yet we should not expect very clean results. I think there's a lot of buzz about machine learning. And the moment you put the word deep out there, deep learning, everyone starts to feel that there is something truly profound about it. But I feel like at the human interaction level, things are quite complicated. We should not expect clean results from any of this. These are not randomized controlled trials or things that physicists do in a lab. These are ongoing discussions on how to design these systems. So with that, I will close and open the floor for questions.